Welcome to the Sweaty Health Podcast. Over the past few weeks, the COVID-19 virus has taken over the world and at the moment is taking over New York. We are experiencing some of the highest, or if not the highest, death rate and sickness in the world at the moment, which is very concerning for everyone. We have two cardiologists today that are working on the front lines of this. And before we get started, I just want to say thank you to them and all the other medical professionals who it's not too different as a fireman running into a fire. You guys are going where everyone else wants to stay out of. So I have an immense amount of gratitude and thanks for you guys doing what you do and taking care of people. And, you know, this is something we can't take lightly. So if you doctors would love to just introduce yourself quick and tell us who you normally work with and, you know, what's the current state, who you're working with now, and we can go from there.
I guess maybe I'll go first. My name is Dan Wachsman. I'm a cardiologist. Dr. Pannella and I, Gaetano and I, both work for Northwell Health. We're based out of Woodbury, which is right near the gym where we all sort of work out most mornings, or at least where we did before the gyms all got shut down. And we previously did just plain old cardiology, although we're now doing a lot of other things, which I guess we'll get into a little bit later. I'll let Tano introduce himself now.
So yeah, I'm Gaetano Pannella. Similar, I work with Dan Wachsman and in Woodbury with cardiologists. We have been redeployed. Our office practice has essentially been shut down. We are no longer working in the office, and we're essentially spending 4 days a week in the hospital now dealing with this crisis. We spend 3 days at Plainview Hospital and 1 day at Manhasset, and that those days are mixed between intensive care unit care and floor care, and that's kind of where we've been living the last 2 weeks. Kind of living in the hospital and handling this crisis on the front lines.
So I know you guys have definitely made your rounds throughout the hospitals for quite some times, you know, in your normal business, but now it's a little bit different with the COVID-19 here. Can you tell us what's different about the hospital that you're going into now?
You know, it's very interesting. So we've been having a lot of conversations about this over the course of the last 2 weeks. The hospital is essentially, I would say 90%, if not more, COVID-19. That's all we're dealing with. And we're all trying to figure out where the other patients have gone. Where are the appendectomies, the acute gallbladders, the cholecystectomies that go on, the acute heart attacks, where are they? We haven't seen many of them in the last couple of weeks. Elective surgery is obviously shut down, but even these emergency cases that come in on a week-to-week basis are no longer, they're not coming in. Certainly not at the rate they were coming in before. So really, what we're handling is 90+% cases is all COVID-19, and the acuity of these cases ranges from patients that are on the floor, admitted, they may need a little bit of nasal cannula oxygen or what have you, to full-blown intensive care unit, ventilator dependent, life support type care to help them. So and that's really the majority of what we're handling. We're not really dealing with a lot of regular stuff that we normally deal with on a day-to-day basis.
So it's almost yeah, please go ahead.
Sorry. And the stuff that we used to do in the hospital, which was really just cardiology, we don't even really do that much anymore. There's very little plain cardiology. Tano and I are both doing almost entirely critical care ICU-based management stuff that I haven't done for 20 years for the most part, that he hasn't done maybe for 10. Managing people who are critically ill with this illness is an entirely different way to do things. And go ahead.
Tano was saying that, where are all these other patients that you had normally been dealing with when you guys worked in the hospital? Is it because, the idea that people don't want to have to go into the hospital if, say, oh my God, I'm feeling like I have chest pain, but I don't want to go to the hospital? Like, what should those people be doing?
You know, we don't know where these patients are. I was in the hospital all day yesterday. Dan was there all day today. Even as doctors, you know, generally speaking, you know, all the diseases that we've taken care of prior to this pandemic, we've learned about in medical school, and we've treated in the hospital, we've treated in the office, and we've kind of known what we were going into. Dan, you can help me and say we're learning from this on a day-to-day basis. Every day, we're sharing stories with fellow doctors and learning about about this disease. We've never encountered it before, and you know we every day it's a new learning experience, and we're sharing stories. We were talking about where some of these cases are with other doctors yesterday, and theories are out there. You know, what's going on with the appendectomies? Why are people no longer getting acute appendicitis? Is it because people aren't eating in restaurants? They're staying at home more. You know, they're eating better. They're under less stress. Is that why people aren't getting heart attacks any longer, you know, or at least at a lower rate?
Mm-hmm.
What's the story? Is it because they're not working? People are sleeping more? We really have no idea.
Mm-hmm.
And I don't think we're going to have answers to these questions for 6 months to a year.
Yeah.
There's a lot of active research that's going to go on from this point on to determine what the causes are for a lot of this. And right now, I think it's anybody's guess. Certainly, there's a reason, because these conditions didn't just go away. You know, there's a reason why they're no longer coming into the hospital. Yet, I was on yesterday and Thursday. Thursday, I saw my first acute heart attack at Plainview Hospital in 3 weeks. Dan, you've been doing this a lot longer than me. When was the last time you went 3 weeks without seeing an acute MI at Plainview Hospital?
I can't remember. It's not even like the big heart attacks that are missing. It's the little bitty ones.
Mm-hmm.
Everything is missing. And some of it is maybe that people are afraid, and the little twinges that they might use as a reason to go to the hospital, they're ignoring that because they don't want to get sick.
Mm-hmm.
The symptoms, we've talked about these problems for weeks now. We just don't know where it's all gone. Somehow Mother Nature has crowded out every other illness in favor of just this one thing. And it really is approximately 90% of every hospital is full of just this.
When's the last time, Dan, because, you know, we talk daily, but we don't talk about our caseload. When's the last time you saw an ST elevation MI, which is not a little twinge of a heart attack? I mean, this is generally considered a more serious heart attack, acute vessel closure, you know, the real deal, the real McCoy, so to speak. When's the last time you saw an ST elevation MI at Plainview?
I can't remember, but it's well over a month.
So I saw one Thursday. That was my first case in at least 3 weeks, and it may be over a month. I just can't really remember even when the last one that I saw, but I could tell you I haven't been paying attention for at least 3 weeks, and it hasn't been that long. So it's bizarre. I mean, I don't want to say they've gone away, because clearly they're happening. And one of the things that we doctors are talking about are these patients staying home? Are they dying at home? Are people dying at home? Are they not coming in? Are they going to, you know, primary care physicians' offices and dying in their sleep? We don't know the answer to this right now, but there is certainly a less, you know, the rate of them coming in is less. And it's not just heart attacks, aortic dissections. You know, when's the last time you saw an aortic dissection? You know, all these emergency things that we see on a, I don't want to say day-to-day basis, but a week-to-week basis.
Drastically dropped.
Drastically.
It would be like suddenly cancer disappearing from the face of the earth for a month. Like, where does it go? It doesn't make any sense.
Never thought of it that way, but that's a really good, I mean, it just doesn't happen. Like, so where are these people?
Maybe besides the virus, everyone's appears to be really healthy. So if you don't have the virus, it could be a false positive almost, because we don't know it. We won't know probably for a while, because no one's looking extensively into it at the moment, I would assume. That's really interesting. How no one seems to be getting all the other stuff that's on a regular basis, the usual traffic.
And when the usual traffic does somehow stumble into the emergency room, it's so unusual that we all talk about it.
Yeah. I had lunch outside the other day with an anesthesiologist, and he was like, I don't understand. We're good. You know, we're good for 10 appendectomies a week, 10 cholecystectomies a week, 10 bowel obstructions a week. Where are these patients? We haven't had one, and they're wondering, where are these patients? They don't. These are not the elective cases. These are the cases that come to the ER. They are just not coming to the ER.
So with them not coming, how has your responsibility changed as a doctor, as a cardiologist, as an anesthesiologist, as whatever these doctors are in the hospital? How has everyone's responsibility changed? What does it look like when you guys walk in?
Well, I'll tell you what I did today. So today, I planted my behind in the intensive care unit, and apart from emergencies that happened on the floor, I did not move.
Mm-hmm.
In the intensive care unit, I saw 4 people who we were seeing really just for cardiac reasons.
Mm-hmm.
And then I saw 11 who really had nothing to do with cardiology. They were just people with the virus who were critically ill, on ventilators, on dialysis, a million things wrong with them. And that's what we do, stuff that I haven't done in almost 20 years.
Mm-hmm.
But stuff that needs to be done because these people are critically ill and there's really a shortage of people who know how to handle it. The people who typically handle such things, so pulmonary and critical care medicine, the people who typically are in charge of intensive care units cannot possibly handle 50 people. There's just not enough people. So we are amongst the closest in terms of our skill sets to assist in helping manage these people. But it's a stretch, especially for me. Again, I've been out of training for a long time now. I needed a little bit of a refresher in order to figure this stuff out.
What's talking about this virus, like what's so unique about this? What makes it different than that regular, the typical flu or any other virus? And when people come in, is everyone showing similar signs, or can it vary greatly? What have you seen as far as that, just pertaining specifically to this virus? I mean, being cardiologists, are people seeing cardiac damage? I've heard a little bit of that. It sounds like when it gets really bad, it goes to pneumonia, and that's when we need the respirators. I mean, is there a certain order of progression where, if you can stop it here and send the people home, we're all good? Or does every case get pretty bad? And, I'd like we were saying before, can you paint like a picture of the typical patient that's coming in now?
So the virus is totally different than the flu or that. It's a different virus. It's a totally different virus. The other really interesting thing about this virus is the spectrum of disease, and we've talked about this at length, Dan and I, and we're somewhat surprised by it. So there have been reports of asymptomatic carriers of this virus. So we don't know that yet, but we're going to find this out in the coming days. There's a new serology test that's going to be able to test whether or not people have had it and been asymptomatic. So Dan and I haven't had any symptoms yet, but have we had it? Body aches, low grade fever, whatever it may be that we may have otherwise discarded as not symptoms of the virus, and went away, and it was in fact the coronavirus. And there are patients out there that seemingly have had it and haven't been to the hospital. And that's one spectrum, the asymptomatic carrier, the low grade disease, all the way to, full blown acute respiratory distress syndrome, ventilator dependent, intubated, and passing away from the virus. Mm-hmm. Huge spectrum of disease, right? From seemingly asymptomatic, not a big deal, to life support.
That's the most scary.
It's scary. It really is. And the most typical symptoms are fever, dry cough, and shortness of breath. All the other symptoms are less common. So the myalgias, the diarrhea, the body aches, the chest pains, all these other symptoms that go along with other viral syndromes are less common in this disease. But people can have these symptoms. So we're seeing patients that come in with diarrhea who end up being COVID positive. We're seeing patients that come in a car accident, and get a pan CAT scan for trauma and end up having CAT scan findings consistent with COVID, and they have no symptoms. And that's a scary situation, because in that particular setting, nobody's prepared to handle these patients. No one's gowning up, wearing respirators and all that, because you're coming in with a trauma, right? So it's somewhat widespread, the symptoms profile. but people can present very sick. Generally speaking, there is we think about a week or so, maybe a little bit longer incubation period. So you get the virus, it sits in your body for a week or so, maybe 10 days, maybe 5 days. Then you start to become symptomatic. The initial symptoms for about another week or so, 6 to 8 days, are somewhat mild. And then we're seeing a lot of patients decompensate in that 6 to 9 day period. That's when the symptoms become really bad and patients start to decompensate. And that's when, a lot of patients will come to the ER right when they get, symptomatic. They usually get sent home, and the ER doctors are telling us they're seeing similar patients come back, and the same patients come back a week or so later, 5 days to a week later. Yeah, exactly. Worse. Respiratory distress, cough, hypoxic, low oxygen saturation in the blood, and then requiring inpatient admission. And then from that point is when it gets, when it gets worse for the patients that are going to be symptomatic.
I know you guys take, diligent notes, especially with patients now. Dan, are you guys seeing any like trends whatsoever, or anything that's getting similar from patient to patient versus like what their symptoms are to, who they are? Are they healthy? Are they seemingly healthy? Are they overweight? Are they, someone who's over a certain age? Are you seeing any sort of trend?
Or who's at
Well, we actually see a lot of trends. We see a lot of trends, actually. I can tell you that there are almost no young, healthy women who get in serious problems. We are seeing a lot of overweight men who get seriously ill. Now, that's the observation I can tell you, having sat in an ICU. If you look around, there's not a single athletic, youngish woman in the entire intensive care unit.
Wow.
There are things that are associated with this, and we've all talked about this. I'm sure you've heard everything in the news. Age is a predictor that you're going to have a bad outcome, high blood pressure. There are a lot of things that are potentially associated with it. We're still trying to figure a lot of it out. But guys like you guys are the asymptomatic carriers of the people who don't get very sick with this at all. You're in the lucky 80% typically in your age.
That is it's a good thing and a bad thing at the same time. So we also have a responsibility as healthy human beings who, if we were to have it and don't have symptoms, we can't go out there and go around someone like our parents who are over 6 years old, or our grandparents, or out, in stores and just be la-di-da. We have to at least respect that. And that's why it's so important to social distance, right? So I do
believe it is working. I do believe that from my, listen, I'm not Anthony Fauci. What do I know, really, right?
Sure.
But I can tell you that the number of cases does seem to be plateauing. The number of new admissions does seem to be plateauing. That is not to say that people are not dying every single day. I will tell you, I put in about 12 hours today, and in the last hour, 2 people died that I was taking care of today.
Wow.
And that's just unfortunately the way it is.
That's definitely not something you guys deal with on a weekly basis, right?
I have seen more people die in the last month than in front of me, than in the last 5 years.
Wow.
It is a dramatic and really very awful thing, because to be honest, we have not found a magic cocktail that really helps, where our understanding is evolving. You'd be better off if you lived somewhere in the middle of the country, which is going to see this last and benefit from our learning and experience.
Yeah.
New York has more cases than anywhere else.
Mm-hmm.
We're learning, and we sit around a table in the morning and we shoot thoughts and ideas back and forth, wondering if we should try this, and somebody will show this paper to us, and we're like, all right, we'll try this today. Let's see how that goes. Mm-hmm. Trying to be as organized as possible so, we don't confuse ourselves with the results. But this continues to evolve. Our understanding continues to evolve every day. But the answer is yes, this is nothing like what our usual day-to-day cardiology practice is. I do not take care of dying people every single day of the week.
That's definitely got to be tough.
It's definitely tough. And Dan and I, by trade, we're cardiologists. So we're out of our normal, job description right now. But I think that, Dan, correct me if I'm wrong, even the ICU doctors and the pulmonologists who are handling this as their usual job description, they will tell you that they don't see this many people die on a day-to-day basis. I mean, it's totally different than anything we've dealt with or anybody in the field has dealt with for a while.
You're 100% right. I agree. I don't think we have seen any disease like this in recent memory. This is not to say that it's the most fatal disease out there, right? Ebola, and there's been much talked about, comparing this disease to others. Ebola, for instance, has a 50% mortality rate. So this has nowhere near a 50% mortality rate. This has, we'll say, maybe 1%, 2%. We won't be sure for probably another year or so.
Well, I'm curious, I'm really curious to see where those numbers shake out, because right now in America, it's about 3%. In Italy, it's 13%. So we're going to have to see where all these numbers shake out. I don't know where the mortality is going to end up. And I think that the numbers will be higher if a lot of countries didn't implement a lot of this social distancing and this, these stay-at-home initiatives and all that. Because
I also heard about Italy is that it's people live longer in Italy, so there's a lot. Well, this is what I heard. That there's a lot of older people already there, and that it's kind of attacked the.
My father was just here earlier, and we had the same discussion, and he was saying the age, and I'm curious to see. In 6 months or 8 months or a year when the data is analyzed, whether or not that ends up being the case or not. I've been to Italy. I grew up in Italy. I've spent every summer in Italy. I could tell you their medical system is not our medical system. It just isn't. If you go to the hospital for a broken leg or, as a tourist, everybody says that their hospitals, their healthcare system is not America's healthcare system. And I don't know if it's that there's older people or if it's just that their healthcare system can't handle what we handle. I can tell you that I have been extremely impressed, despite what the media is saying, about the surge capacity of our healthcare system. We have created beds where there were not beds previous. We have found ventilators. Dan, correct me if I'm wrong. Some of these ventilators at the patient's bedsides, have you ever seen them before? Where'd they come from?
I think some of them are older than I am.
They look like an iPad is more technologically advanced than some of these ventilators that we're using. They're working. Don't get me wrong.
Doesn't matter.
Yeah, they're doing the job. But I mean, we really have found a way to handle the influx of patients, the influx of volume. I've seen articles that we're doing 3D printing to be able to get a new adapter to the piece that hooks up to the ventilator. I mean, this is America. We have money. The healthcare system has money. We thrive in these situations, and we're doing better than other parts of the world.
It's really good to hear. I mean,
you look at Spain and Italy. I know it's not sexy to say this, but I just don't know that they have these capabilities.
Yeah.
And I think right now everybody's saying, yeah, they're old, but it may be. We'll see in 6 months, and I hope that's the case. But I'm going to be surprised if it's not a function of their healthcare system being able to do what we're able to do in America.
And we see a lot in social media now is that in the beginning, like we were so worried about supplies and enough doctors and nurses and things like that. How are you guys handling it, and what does that actually look like in the hospital? Especially maybe not this week, because maybe you've gotten the swing of things, but like when you first started working on this, what did it feel like? What was it like in the hospital dealing with the craziness of it?
I think Dan and I are perfect examples of this. I mean, he and I are doctors that have been the word they're using in the system is redeployed or repurposed to handle the influx of patients for this. And, our expertise, if you look at who's able to handle critical care patients, it's really, it's pulmonary critical care. And then after that, the next best person is probably, a cardiologist. We have critical care training as part of our fellowship training in the CCU or the coronary care unit. And we can handle this, but it's certainly not what we do on a day-to-day basis. So we've been totally repurposed. I don't think we're running out of doctors. Dan, do you think we're running out of doctors? I mean, we're stretched. We're doing things we've never done, or you haven't done in 20 years, myself 10 years. But I don't think there's no patients that are being cared for by, hospitalists yet at this point that are critically ill.
Not sure if Dan is frozen or he's.
he seems frozen.
Oh, here we go. I admit he was frozen.
Yeah, so he seems still frozen. So at this point, we're at least at Plainview, we're handling it, and we're meeting the challenge right now. But we're definitely seeing doctors that are not in their usual role. Manhasset, same thing. Doctors are working out of their roles to handle this. So people are definitely not in their usual role of care, of patient care. Same thing with nurses. So, I've seen nurses in the ICU and in the critical care units that, normally work on the floors,
Mm-hmm.
and they're not usually handling critical patients. So they're working outside of their own roles. Everybody's doing a great job. It seems like everybody's handling the task. And I can honestly say, I don't think any patient has gotten suboptimal care at this point,
Yeah.
which is which is great, but people are definitely working outside of their roles. I can't speak to, there's a lot of tents that have been set up, and the USS Comfort is in Manhattan.
Sure.
Obviously, I don't know what's going on in those in those settings, but it seems like everybody in our setting is at least functioning. A hospital, though, you were asking a little bit about what the hospital looks like. It is unrecognizable to the way it is when we normally walk in on a regular day, call it a month ago. Okay. When you walk into the hospital now, everybody's got to put a mask on. There are no visitors. So that's another interesting point, right? A lot of these patients are alone. They're alone for their entire hospitalization. If they're going to die, they die alone.
Now, let me ask you something. You say everyone's got to put a mask on. Is that handed out to you? Do you have to bring your own? Like, get to the details. I want to hear a little bit more about that. We were hearing like people are wearing masks days in and days out, same mask. Do you now have supplies? I know in the beginning people were saying that they didn't have supplies. What does it look like?
So the masks.
Can you guys hear me, by the way? Because
Yeah,
I
we
lost
got you
a
back
little
in.
bit.
Yeah.
Okay.
So the masks are given to us. The surgical masks are given to us, but the mask that really works most effectively for this is called an N95. It's a mask that fits a little bit tighter over your face, and it filters out more particles, more virus than the standard surgical mask. These masks are in short supply. They're not overflowing in abundance all over the hospital. In America, we're used to everything being in abundance. We're used to never having to even wonder. I think before this crisis, I've never once went to work thinking that I wasn't going to get a mask, wasn't going to get a gown, wasn't going to have an N95. The thought, honestly, never, ever, ever entered my head. It was a non-thought. We always would have had one. Since this, everybody now is thinking about these masks. N95s used to be outside the patient rooms, used to put one on when you needed one. It was very rare. The only instance that we ever really needed one was TB, when you were ruling a patient out for TB. And you'd put one on, you go into the room, and you probably would never need it for the rest of the week unless you cared for the same patient.
And you would toss it right in the trash afterwards. Yeah. It was considered a disposable item, like a pair of gloves.
Right, exactly. So now, these masks are in high demand because everybody needs these masks to handle all these patients. And now remember, these patients comprise 90% of the hospital. So these masks are in high demand. These masks are now being held in the nursing offices and in the nursing managers' offices and all that, because people just can't be trusted to take one, use it, and throw it out. So now all of a sudden, and this is the first time I've ever read the fine print on these masks, but the word is that they last for 4 hours is the optimal time when these masks stop being effective. Right. So Dan, what's the current, we're being asked to use them for 3 days, 4 days?
Well, I'll tell you, I wore it continuously today for 12 hours.
Right.
So continuously, right? Yeah. And the only reason I didn't take that one home is because when I took it off today, finally, the strap broke. So I tossed that one out. Mm-hmm. But I have a supply in my truck of things that I have used. Mm-hmm. Now, I have not personally been struggling to find N95s. I mean, I get a new N95 when I go to the hospital. I keep the old ones in reserve in case I am going to need them again, because you never know when we are going to run out. So I have not had trouble getting them. I just, sign a piece of paper and they give you a new one on a daily basis, which you're supposed to really do if you're in the intensive care unit anyway. There are certain things you might be exposed to when you're in the intensive care unit, intubations, extubations, certain procedures that make it more likely that you'll be exposed to the aerosols, as we call them. Mm. And in those cases, they do recommend that you change your mask afterwards. But we're keeping them.
Yeah, and how is the staff doing around you? We have a friend who works in a hospital, and she says a lot of her that she works on a day-to-day basis have been getting sick. Have you noticed there has been a lot of doctors and nurses contracting the virus, or have you guys really been doing a great job keeping those masks sealed and not finding too much of the staff getting sick?
Some staff have definitely gotten sick. We all have friends in hospital who have gotten sick. Some of them have come back now because they got sick sort of early on. But people are definitely getting sick, and that goes for people in the hospital. There are entire practices that shut down because all their staff got sick.
Oh, wow.
And that's part of the reason why our practice shut down. We sort of shut down pretty early in an attempt at keeping ourselves healthy. We all sort of knew that we were going to be first people that were going to be called upon to staff those ICUs, because there's very few people in the hospitals that are actually qualified. I mean, they have plastic surgeons running around trying to run an ICU. If they were ever qualified, they're not qualified now. At least cardiologists, we do some critical care and we have a certain skill set that's useful. But we knew we were going to be asked to participate, so we sort of took ourselves out of some of the riskiest situations, closed our hours down a little bit, and that was well before the health system actually asked us to do it, for the same reason, to protect us from the onslaught and try to keep us healthy so we could do what we're doing now.
It sounds like you guys were definitely proactive in a I guess business standpoint and health standpoint. How can everyone else now continue to be proactive to stay healthy?
In the immediate, like right now, what's our best chance at stopping or flattening the curve, as they say? Because it seems like we're a couple weeks in, we're seeing it plateau because it's been about 3 weeks. And when you talk about the timeline from the second you get it, it seems like 3 weeks is kind of a full cycle.
Well,
so
here's what I would say.
Yeah.
You know, it's going to be 70 degrees and sunny soon, right? And everybody is going to want to go out and hang out with their friends, and everybody is going to forget what this is all about. People get spring fever. It's going to happen. And what you have to understand about the flattening of the curve is that it just means we are prolonging this. The notion behind the flattening of the curve was not necessarily that we're going to all stay healthy. What it means is that we get sicker as a group more slowly, and we don't overwhelm the health system. That's the point.
100%.
If we were all going to do, I think it's Sweden that did this, which is instead of social distancing, do herding and try herding HERD, get everybody together and get sick all at once. We would all get sick all at once. There'd be a lot more dead, but this would have been over in a month. Instead of what we're likely to see, which is this may last for many months or perhaps over a year. So what we have to do is really not get cocky. We have to understand that this is going to be a long, unfortunately drawn out process where we're going to have to change some habits, maybe permanently, but you're not going to be able to go out and chill with your friends and play Frisbee on the grass on the first sunny day that you're going to see in a week or two.
Have I shook my last handshake?
Interesting.
Wow.
So, you know, there's a lot of talk about whether or not this is going to change us culturally as a society. Are we going to do things the same way we did things before once, you know, life goes, you know, quote unquote, back to normal? And no, you haven't shook your last hand, in my opinion, but I do think that Americans are going to have a little bit more of an awareness about communicable disease and infectious disease. And getting back to, you know, what Ross was asking about short term. So, you know, Dan touched upon this before, younger, healthier people who take care of themselves, you know, more athletic, especially women, they do better with this disease. But that's not a short-term fix, right? If you're an obese, you know, person that is not taking good care of themselves, nothing short-term that you could do about it. The short-term thing to do about this is to remember it's still an infectious disease. It's still a communicable disease. It's still passed person to person. It's still spread, you know, by picking up the virus on a surface and not washing your hands and touching your face and having interaction with other human beings. And in the short term, I think that people practicing proper hygiene and social distancing, I think are going to do better to not contract the illness and to not contract the virus and keep themselves healthy. You know, short term,
I think we all just need to know our own personal responsibility. And it's not just whether you yourself are going to get sick. It's whether you could potentially get someone else sick. You just have to remember that this is a group problem. It's not just an individual pursuit. You don't really know if you have it, and you never do, because there are plenty of people, especially in your age group, who feel perfectly fine and can pass it on to 100 people very, very easily. So
without
everybody
even knowing.
simply just has to remember that it's not just about you, and you have to be careful, not for your sake necessarily, but for the sake of others. That's where the social distancing comes in.
Well,
And, you know, I really do think that we have flattened the curve. I mean, the hospital, you know, what we see in the hospital. Listen, I wake up every morning. I was off today. I didn't work today. I woke up this morning, had a cup of coffee. First thing I did was log in and look at the ER census at Plainview and Manhasset, and look at the inpatient census. This is what I do every morning now. I do it out of a sense of, you know, curiosity. What are we doing? What's going on with the disease? What's going on with the curve? And, you know, we're definitely seeing on a day-to-day basis that the numbers in the ER and the numbers admitted are at least stabilizing, if not decreasing. Mm-hmm. So what we're doing as a society is working. Mm-hmm. It is working. The interesting question is when and how to go back to normal. Right? When do you go back to restaurants? When do you go back to work? When do you, quote unquote, open the state or open the country again? And is it a stepwise thing? Is it a open the floodgates type thing? And you know, I'm certainly not an expert in this. I don't know if anybody's an expert, because we never really dealt with this before, but there's a lot of opinions. And, you know, how do you do this? You know, do you start with the, you know, most essential people and work to the least essential people? Do you utilize maybe some of the serologic testing that's coming out and let people who have, you know, had the disease and have antibodies to the virus go back to work and, you know, function in their normal capacity, regardless of whether they're essential or not? And there's no right answer to this. We've never dealt with this before. Mm-hmm. We've never, ever dealt with this before. So, you know, it's going to be very interesting to see how we do this. But so I personally feel, Dan, I don't know your opinions, but I personally feel that opening the floodgates and just saying, you know, April 29th, that's the day that we're going to let kids go back to school and let, you know, everybody go back to work, regardless of what the situation is. I feel like that's the wrong approach. That's just my opinion.
I think we all do. And I think we've all had conversations. I think I can't remember the last day that went by in the hospital that I didn't have a conversation about what somebody thought about when we're going to go back to normal.
Yeah.
You know, can you imagine yourself sitting in Yankee Stadium anytime soon? Can you imagine yourself, you know, on the TSA pre-check, you know, line trying to get on an airplane? You know, it's hard to imagine going back and standing in close proximity when all you're wondering is if the guy next to you is going to cough on you.
Right.
So this is going to be a challenge, and I don't think any of us really know. I think we are going to have to eventually go back to work. The country has to open again. We all have to go back to school.
It's all very interesting. And Tony, you touched on someone who might have the antibodies, say they had the virus. Is this a one and done type of thing?
So, you know, we've had a lot of conversations about this too, and please understand, this disease is brand new. It started in November in China. You know, I'm not confident about a lot of the data that we got out of China. So figure, you know, it landed here early 2020. We have a very limited experience with the disease. So not a lot of people know for sure. The right people to ask about this would be hematologists and infectious disease experts. The conversations that I've had with them is that they feel that it is most likely one and done. And if not one and done, if you get it once, even if the virus were to mutate and take on a slightly different form and you got it again, it will be a far less severe disease. Mm-hmm. So, you know, you would get something, you know, much less severe. Speaking to that, you know, they feel that might be some of the reason why women and children are somewhat less affected by it. So, not to get into the details of this, but the coronavirus is a human coronavirus. Coronavirus is a broad category of viruses, and it's similar to the virus that causes the common cold and the virus that causes a lot of the respiratory illnesses that kids get. So there is a thought as to why women and kids are not as affected as men, and you know, worldwide or even in America, a lot of kids who are around each other get this human coronavirus as part of these respiratory illnesses, and maybe this coronavirus, COVID-19, has a lot of genetic similarities to the human coronavirus, and there is some level of immunity in these patients, in kids and in kids, that's why they don't get as severely ill. And who's around kids more? Most teachers are women. Most, I hate to be a gender role kind of guy, but most women
Parents
are
are
watching
home.
kids.
Yeah.
Right. So maybe that's why, maybe they have some type of immunity to the illness that makes them less susceptible to it and get the disease in less form. These are all theories. There's nothing
Sure.
proven here.
Yeah.
Nothing proven. And most men are away from kids and at work most day. And maybe that's why we're more susceptible to this. And that speaks to, is there some level of immunity that you're going to get, with being susceptible, being exposed to it and having gotten it. So the answer is we don't know, but we do think that it's more likely a one and done. And then once you do get it, if you do get it again, it's going to be less severe. And that's a big thing why they want the serologic antibody testing, to be able to let people go back to work. And the other thing is it's got to be quick. People want it to be, a finger stick or a heel prick test to be able to have an answer relatively quickly so you can go. I heard today, people are thinking even with travel and flying on a plane, maybe one day that's going to be a way to get on a plane, get tested.
Maybe you get like a certificate on an app and you just,
Yeah, or even a finger stick before boarding. Who knows? I mean, I don't know how they would do that, but there is going to be some level of immunity that's going to protect you from future disease or make it less severe. Vaccine. The best estimates I've heard at vaccine are, if we're really lucky, it's going to be a good Christmas present. We're going to have it by Christmas. More realistic estimates, early 21.
Mm-hmm.
But if people really get on board, there's an ID guy at Plainview, infectious disease guy at Plainview that's been really intimately involved with a lot of this. He says this is a very vaccinatable, if that's a word. A very easy virus to create a vaccine for, because it's an RNA virus. It's single-stranded. He said, everything about this virus makes it very easy to develop a vaccine for. It's just, again, you have to develop it, you have to make it, and then you have to be able to develop it in mass quantity to be able to distribute it and vaccinate people.
Well, people are really working on that. I saw something the other day about Johnson and Johnson. So, usually the process to make any drug, any pharmaceutical, any vaccine is a many years long process, typically, to get anything from bench to syringe. With this particular thing, because the stakes are so high and the demand is so great, Johnson and Johnson has decided that they have a good candidate, and are planning on making 1 billion doses available before it is fully tested, just in case it actually works. So
Wow.
they're ready to go, and they're not going to be the only ones with that plan. They are going to be, the instant it's ready, they're going to have 1 billion doses ready to distribute across the planet.
And what's the
and
timeline?
I'm sure that there are pharmaceutical companies similar notion. They're starting trials in September, I heard.
So Christmas.
Yeah.
What is the best bet for medications right now? The
hydroxychloroquine. So
Yeah.
we and again, we've talked a lot about, these are all conversations that Dan and I have been having on a day-to-day basis, and information changes. I feel like every week I go into the hospital, it's a little bit different. So hydroxychloroquine, the current thought process is that it doesn't do, it's almost like Tamiflu. Okay, you've heard of Tamiflu for influenza.
Sure.
If you take it within the first 24 to 48 hours, it's effective. It decreases the duration of the disease. It helps you. Hydroxychloroquine is thought to be similar to that. So it's helping if you get the symptoms early, you take it early, it's gonna help you early. Patients that we're seeing, remember I talked to you about that time course a little bit. You get the disease, you're symptomatic for 6 to 7 days or so, and then after that is when if you're going to become really sick, that's when you become really sick and go to the hospital. So the patients that we're seeing in the hospital, hydroxychloroquine is thought to already be too late for that particular drug to be effective. So we've actually not been using it any longer in the hospital.
All right, so that's pretty interesting, because that can, I guess, help a few people. So say you were feeling some form of symptom, what's the first thing you should do?
Call your doctor.
If it gets to a point where you feel like you need to go to the hospital, do you go to the hospital?
Yes.
Absolutely.
If you're sick enough where you feel short of breath, coughing, and you're really having difficulty breathing, you should absolutely go to the hospital. No question about it. I think if you have a very mild illness, you have some of the symptoms.
Say you have a fever for, I've already spoken to a few people who have had it. They said it was the worst 13 days of their life. And, they've had a fever for 13 days straight, cough, like every cough felt like pins and needles through their body. The only thing that got them through it was hydrocodone cough medicine that alleviated the cough. They said, getting up and going for some form of a walk every day, getting the blood flowing, and surprisingly enough, their faith got them through it. But what else do you see can help people get through this who are on the brink of, ventilator death and who have come out of it? Have you seen that kind of patient?
I mean, that's a very different situation. So on the brink of ventilator death, they need to go to the hospital. You have to go to the hospital. You have to be likely at that point, you're going to need supplemental oxygen and all that. Patients that have a more milder illness, like what I think you're describing, somebody who has febrile, has some cough, has some shortness of breath, difficulty breathing, but they're not quite at the point where they need to go to the hospital. One thing that patients have been telling me that's been helping is a lot of humidified air. Mm-hmm. So these humidifiers in their rooms. So another interesting thing about this disease is that the secretions that it creates are different than secretions from like other respiratory illnesses. They're almost Dan, what's the word they're using in the hospital? Like Darshan's been using TPA because they're like fibrinous secretions. They're like not mucoid.
Dumb that down a little bit.
So they're almost like the same. They have like a protein in it that is like a collagen type protein or like a soft tissue type protein, and not just like a mucoid type of like respiratory like loose secretion. Like the secretions are thicker. They're more difficult to break up. They're harder to get up. They're harder to cough up.
That loose cough that I guess when you're sick and it feels good, you're like, oh, I can finally get it out of me.
Right.
So seeing that.
Yeah,
that's
nobody has that.
Nobody
has that.
It's much more difficult to get up. So patients that I've spoken to who have dealt with it at home, and listen, we're talking about an N or a patient selection I've talked to of a dozen. So it's not like I'm talking to thousands of patients that stay home, but the patients I've spoken to, they say that, they really try to keep it loose. They use a lot of humidified air, warm showers, so they can cough this crap up a little bit easier and kind of get things mobilizing and get things moving. Even in the hospital, when patients are intubated, a lot of patients, once they're intubated, the chance of coming off the ventilator is very, very low. So it's 20 to 30% of coming off the ventilator. At Plainview, they've been injecting something called TPA, tissue plasminogen activator, that breaks up this fibrin a little bit to see if that helps. Again, we don't know if this is going to help or not, but it's one of the things that we're trying because the secretions are so thick and so dense and so hard to get rid of. So, the patients that stay home, they do tell me that the more moist they keep everything, the better they feel, and the better they do. So
it's very humbling that we really don't know how to treat this. We can't even agree on what is actually wrong with the lungs. So what we say is wrong with the lungs is something called ARDS. So it's acute respiratory distress syndrome. And really all that means is that there are infiltrates or sort of like a pneumonia type process in both lungs, and it's not because the heart has caused the problem. That's really all that means. Mm-hmm. But that could be from any one of a number of things. The classic pneumonia that people get, okay, we expect that to cause that problem, and you treat that in a particular way, but we're actually thinking that this is a lot less like your classic pneumonia and more like something called high altitude pulmonary edema. The changes are actually very similar, and we are starting to migrate away from treating this illness like a typical infectious lung problem and more toward that other problem. Mm-hmm. And that pertains to how we use a ventilator and how early we use a ventilator. And that's part of the reason why the ventilators are not being used as quickly as we thought they were going to be. Initially, the guidance was, well, when somebody looks like they're going to fail, put them on a ventilator early. Mm-hmm. And that's why everybody thought we were going to need a gazillion ventilators. But in fact, those numbers you'll see reported are not as bad as we thought they were going to be. There are enough ventilators for the most part right now, at least locally.
Well, we've also changed our approach slightly.
And that's because we longer ventilate people early. We stopped doing that because they don't do well when we intubate them. We can non-rebreathe their masks. We tolerate low oxygen levels. We hope for the best because we find now that those people are doing better when we don't use a ventilator as opposed to when we ventilate them early.
So there's some data that came out of China that was I don't want to call it, it's not what we're seeing here. So in China, they told us that early intubation and early use of a ventilator would be better. We're finding the opposite here. We're finding that once patients are put on a ventilator, they're doomed. And we're changing, we're somewhat changing our approach to these patients. So a patient whose numbers and who looked a month or two ago that they needed to be put on a ventilator, we're starting to think, should we tolerate lower oxygen saturations in these patients? Should we tolerate a little bit of a higher respiratory rate in these patients? Should we put them on their stomach? That shows to help a little bit. Most hospitalized patients are on their back. Prone means putting them on their stomach. That tends to help these patients. So we're like yesterday, I went to see a patient on the floor, not in the ICU yet, because now you need to be intubated to be in an ICU, who was saturating, 78%. We put a non-rebreather mask on him. He came up to 82, breathing at 30 breaths a minute. We put him on his stomach. Yeah, but normally we would have intubated that patient. But now we're changing our approach a little bit. We know that the ventilator is bad. We know that they don't do well when they get put in the vent. And we're tolerating these patients at lower oxygen tensions, putting them on their stomach and saying, listen, ride it out. Ride it out. Lay on your stomach, put a non-rebreather mask on you, keep an oxygen saturation 82 to 85%, and stay off the vent. And they seem to be doing okay. They seem to be doing better than if you put them on the ventilator. The other thing that we should talk about is, Dan was talking a little bit about the difference in disease compared to ARDS. The other thing we're seeing is that the patient's own immune system, the immune response, is having a tremendous, it has a role in the illness, the cytokine response, the immune response to the disease. So the initial data out of China was that steroids are bad and immunomodulator medications are bad, and we're not finding that.
We're finding packs, like things like that.
No, like steroids and monoclonal antibodies to like immune factors like interleukin 1, interleukin 6. Interleukin 6 seems to be the one that's the most likely to benefit from blocking. But in China, they gave patients steroids up front. So a guy like you shows up to the ER. I don't feel so hot. I'm febrile. I'm having a little bit of difficulty breathing. They would give patients steroids, and those patients did worse. Early steroid administration did worse. But we're finding that when patients get sick at that 6 to 8 day mark, giving them steroids and giving them monoclonal antibody to interleukin 6 or interleukin 6 receptors helps them at that point when they get really, really sick. And we've been finding success with not intubating these patients, tolerating lower oxygen saturations, non-rebreather mask instead of the ventilator, steroid administration at that point, and monoclonal antibody medications to interleukin 6 at that point when they get really, really sick. And as of right now, that's been our general treatment approach as opposed to, intubate immediately and pray. That's kind of where we're at right now. And I think that at least for the younger, less comorbid patient, we're doing a little bit better with that. Dan, would you agree with that? Has that been somewhat your experience?
I think it has. And I think actually there's a useful tangent go on. Just a lot of people are wondering, we all saw that picture of that 40-year-old nurse from Mount Sinai who was pretty healthy on the TV screen and we see pictures of some 8-year-olds who somehow leak away and don't get all that sick. What's the difference between the 4-year-old who dies, 80-year-old who's sick? And this has to do with the immune response. So, we all get the same virus. And what is different between the person who has a mild illness and a little fever and some muscle aches and is better in 2 weeks, what is different between that person and the person who is critically ill on a ventilator is really how your body responds to the virus.
So this is
So you know, you putter around for a week and you fight it off for a little while, and you develop, you know, antibodies and you fight it off. That's great. That's the way viruses are supposed to go. But there are some people who are a little bit unlucky. And those unlucky people, instead of having the normal response and they're better with a couple of weeks of fever and body aches, their immune system goes haywire. And it throws everything, including the kitchen sink virus, and it makes all your tissue organs all of a sudden very dysfunctional. And you sort of drown. You cannot breathe. Your lungs stop working, and other things fall after that. And that's really what it is. And that's where we're trying to figure out how to keep the immune system from getting in its own way and causing this exaggerated response. So is it steroids? Is it some other chemical that we can use to interrupt what the immune system normally is doing in these people who get sick, to keep it from going over the edge and just kind of keep it on a low simmer so that you fight it off, but you don't cause the person to drown in their own food. So that's really what the problem is, the difference between the sick people and
so that's one of the buzzwords I keep hearing thrown around is immune compromise. And I can't help but think of a personal experience I had when I was younger. I had really bad asthma. And some of the things you were talking about, it's like, oh, that's what it sounded like to have a really bad asthma attack. But it sounds like these people are having that for 10 days in a row. And I remember that's what I used to go on prednisone, which I believe is a steroid.
Yeah.
So, I would assume people with a certain level of like autoimmune disease, like an overactive immune system, especially something like asthma, they would be at very high risk of having bad complications with this.
Yeah, asthmatics are definitely doing worse. Asthmatics, COPD, you know, congestive heart failure, they're definitely doing worse. Definitely, without question, the uptick to them doing worse. Just to get back to the immune response and all that. So the drug that we're using at Plainview is called tocilizumab. There are a couple of these drugs that, you know, that interact against interleukin-6. So yesterday, and take this data for what it's worth. This is not like a randomized controlled trial. It's very, you know, this is preliminary stuff, and that's all we have right now because we don't have, you know, we don't have the benefit of years of experience with this virus. So we asked the pharmacist to look at the patients that we administered this drug to, and we asked her to tell us who they were, which ones got better, which ones stayed the same, and which ones proceeded to intubation. So of the patients that we gave this drug to, and you know, up front, when they get sick, when they start to have respiratory distress, when they start to need more oxygen, 40% got better, 40% stayed the same, and 20% proceeded to intubation. So that's big. I mean, and again, it's not, we're not comparing this to a group of patients that doesn't get the drug, so it's not controlled. But nonetheless, at least we know the patients that we're giving this drug to are at least staying the same or getting better and not proceeding to intubation.
That's a big number.
It seems like it to me, because before we started really using this, it seemed like everybody was proceeding to intubation, you know, and not coming off the vent. So, you know, we'll see. I mean, you know, there's going to be a lot of crunching of numbers.
Yeah, statistics and the analysis of it is going to change. We're going to find out a lot of information as the time goes on and people start giving information out.
100%.
You were talking about respiratory rate of like a 30. Normal is, I know mine, like when I sleep, is like 13.
12,
right?
yeah, 12 to 15. Yeah.
So
30 is you're in trouble. Ordinarily, he would probably buy you close to a ventilator already. Like if you see someone breathing at 30 and it's a real 30, that person's in trouble.
Yeah.
But
something's up. Yeah.
So
what's really that every day of the week.
What's really interesting, I wear a Whoop. If you guys haven't seen this, I may have talked to you guys about it. It measures HRV and heart rate variability and stuff like that, and heart rate reserve. And they added in respiratory rate while you sleep. So they have thousands of people on it, and they added a daily journal. So the questions you have to answer every single day, like, were you able to complete a workout? Were you able to do this? So what they found was all the people who have Whoop, I'm I'm not sure if I'm going to be perfectly right, but of all the people who have Whoop, the ones who said they contracted the virus, they checked their statistics, and what they found was their respiratory rate went up about 15 to 18% a few days before they contracted the virus. And from that, they were able to tell, because they were not able to finish a workout. So I spoke to another person who ended up getting the virus, and they weren't able to finish a workout because they felt too out of breath. And it sounds like that respiratory rate might be like something that can help with figuring it out.
Well, there are a lot of soft indicators, right? So if you take a careful history, you'll find that some people didn't sleep as well. Some people's resting heart rate maybe went up 5 beats a minute. There's probably a lot of soft indicators like that, where if you went back and looked, you'd be able to figure out, maybe 2 days before the person figured out they were sick, you'd know they were sick if you were paying attention.
Yeah.
I'm not sure how useful that really is, but yeah, you could probably tease out a couple of things.
Mhm. So we've spoken a lot about short term and like how we can, I guess, help ourselves right now. But this is we call it the Sweaty Health Podcast, and we're all about really trying to help people, now and for the long term. So, as a normal person, what is your best way to increase your immune system for the long term?
Right, exercise when you can. A sprinkle of sunshine is good. All the things that you probably talk about, every time you have this cast. Healthy habits, will help keep you healthy. They are not a guarantee that you won't get sick, and they're not a guarantee that if you get sick, you're going to do okay. There's no guarantees. Some of it is luck, and I think we're seeing that a little bit. You can't predict what your immune system is going to do.
Mm-hmm.
But I can't believe that anybody's going to go wrong eating lean proteins and more complex carbs and trying to get a workout in almost every day.
Mm-hmm.
That can only help you over time.
There's been reports with all the doctors we've talked to of like perfectly healthy people, getting sick, getting put on a ventilator, and maybe even sometimes succumbing to this virus. I can tell you that for myself, I have yet to see a perfectly healthy young person, normal body weight, normal body fat percentage, exercising regularly, sleeping the right amount, eating properly and all that, get this disease, end up on a ventilator and die. Me, Dan, tell me if you've seen that person. We hear stories, and everybody's like, oh, this person got sick, died, they were healthy, no medical problems, which no medical problems doesn't really mean anything until I look, for myself and, look at their fasting sugar. And
yeah, I also think someone's version of healthy might be different than ours.
It might be. Yeah. Right. So like, I could tell you that for myself, we have a 30-year-old intubated in the ICU who may not make it. He's morbidly obese.
Mm-hmm.
He's morbidly obese.
Mm-hmm.
So I yet have not seen that patient. I have not seen the patient that's perfectly healthy, doing all the things that you guys probably talk about on this podcast, or that we talk about, Scott, on a day-to-day basis, get sick, get on a ventilator, and die from this disease.
Mm-hmm.
I think there's a lot to be said for, regular physical activity, a proper diet, sleeping right, all that. So that's the best thing that people can do for long-term health. And it becomes the best thing that people could do in the event of something like this that comes up out of the blue and could potentially take your life. So it speaks more to taking proper care of yourself every day.
Awesome.
Dan, have you seen that patient yet, by the way? I mean, I know we see slightly different patients.
I have not. Well, listen, if you look at all the papers that have been written, that person is out there.
Mm-hmm.
But if you're looking to see, who's more likely to get in trouble, clearly the person who's unhealthy is much, much more likely to get in trouble than the person who's healthy.
Mm-hmm.
So while being healthy is not a guarantee that you're going to do well, it's a hell of a better option than deciding you're going to let yourself go to shit and hope for the best then.
Right.
So
I was
being
talking
healthy is a much better way to go about this.
So it's a bell curve. So there's tails on the bell curve, and the tail would there's definitely a tail on the end of the young healthy person, but it's going to be a few cases when this is all said and done.
Yeah, the exception and the rule kind of thing. Where
right, exactly.
The news might focus on the exceptions of, oh, this young person's super fit, and maybe that's a way to say like, hey, listen, anyone can get this, but it's by far from what you're telling us, the rule of what you're kind of seeing at the moment.
Absolutely.
Yes.
So
So the two of you guys are unlikely to get sick.
right. All the young people I've seen who have been sick have been obese. And Dan, you and I have talked about, there's got to be more to it. Is there a genetic thing? It just can't be that you're a little bit overweight. Even coronary disease. Your point is very well taken. I thought about your point after you made it on the floor that day. Why should a stent, 3 years ago, make you more likely to die from this virus? Right? You have stable coronary disease at that point. You're healthy. You're active. But listen, the fact that you had coronary disease to begin with indicates some level of vascular damage, some level of endothelial dysfunction. If you want, it makes you a different patient, in my opinion. But
Oh, man. That's sad to hear.
There's something there is definitely something genetic that we're going to find out in the future. But the people that are purely healthy, taking good care of themselves, seem to be much less susceptible.
Awesome.
Doctors, this has been incredible. I think Scott, would you say we covered, I think, all the topics we wanted to talk about and a lot more. I'm going to have to listen to this again for sure.
Yeah. We definitely, I was scrolling through a bunch of the questions that we had written down and you guys covered without us even asking. So first off, I definitely want to thank you guys. You guys are both my clients and you guys are wonderful for coming on here. It's great to see your face. I know I haven't seen you guys. We're used to seeing each other every single week.
We miss you guys, man.
Yeah, we
do.
I'll miss you guys for sure.
We got to try not to get fat while we're not with you.
Yeah. It's such a wonderful thing what you guys are doing right now. You were thrown in it, just like Ross said when he started the podcast. You guys are the people running in that burning building, and I'm sure many other people greatly appreciate what you do.
Thanks, guys.
Thank you.
Thank you.
Appreciate it.
Thanks for inviting us. This is my first podcast. It was awesome. Thanks.
Awesome.